Hello everyone, my name is Rajiv Acharya. I'm from the Population Council. Good evening, good afternoon, good morning to everyone who are joining from different parts of the world. Welcome to the 7th edition of the webinar series of NDQF. As you know that NDQF brings to you a discussion, a dialogue on different parts, different data quality issues. And today's topic is on death registration and causes of death. Causes of death data in India. We will talk about the coverage, quality aspects, as well as coverage, quality and coverage aspects of both registration of death as well as causes of death. We have here a panel of eminent people who will be talking about these issues. I will come to that in a minute. Before that, first some ground rules. During the session, when the panel is speaking, all in the audience will be in mute mode. During any time in the session, do type in your questions. We will get all those. We'll try to answer those questions later on. At the end of the panel discussion, during the question answer session, please raise your hand if you want to speak a question. You can ask a question that way, or you can always type the question. In case you want to speak, we will unmute you. So before we go on to the panel, we're going to try this time with some fun activities where on the topic of death registration and MCCD, medical causes of death, certification of death. It's not a fun topic, but we are trying to make it fun. We will be doing a short quiz session where you can actually answer 3 questions as displayed on the screen. Please look for the link that is posted on the chat. Has a link been posted, please?
Yes.
Okay, you can click on the link and answer the question as we go one by one. If you have problem with that, you can go to menti.com and then type the code 5512277 5512277. If you click the code, if you click the link, you don't have to do anything. Yes, first question. Give 30 seconds to do this. Please go ahead and put your answer in menti.com. Come on, audience, it's for you. We have only 2 answers so far. Great. So you see, cancer is the highest, tuberculosis, heart attack, heart disease. 10 more seconds. Okay, next question. So you can see the answer. Heart disease, cancer, tuberculosis are the three main that has been answered. Go to the next question, please. What is the coverage of death registration in India? There are 3 options: 40 to 60%, 60 to 80, 80 to 100. Let's see what the audience says. Get the right answer during the discussion in the panel. 10 more seconds. Okay, go to the next. The highest is 40 to 60. Second one is 60 to 80. Nobody believes that we have more than 80% coverage. Go to the next. This is a really fun question. The life expectancy of Indians is more than that of Bangladeshis. True or false? Come on, put in your answers. Okay, time up. So 71% false and 29% true. The right answer is false. Okay, thank you so much, everybody. With this, we start the session. I would like to introduce you to the moderator of the session today, Dr. Neeta Goel. Dr. Neeta Goel is the Senior Program Officer, Measurement, Learning, Evaluation at the Bill and Melinda Gates Foundation. And she works a lot on health and nutrition, on the women's collectives, and also several initiatives on data ecosystem, strengthening of data ecosystem, etc. She has been engaged in monitoring evaluation work for over 20 years now in the field. Many of you know Neeta, and she will moderate the session and introduce the panel also to you. Over to you, Neeta.
Thank you so much, Rajiv. And hello, everyone. Thank you for joining us. Could I just request the NDQF team to confirm you can see my screen in slideshow mode?
Yes, we can see your screen.
Okay, thank you so much. So thanks for joining us this evening. It's going to be an exciting session, I can tell, just given by the start that we had there with the audience poll. And as Rajiv said, we're going to find out the answers to some of those questions as we go along. So I'm going to take the next few minutes just to sort of set the stage for our topic of discussion. And so I think a good place to start is actually to discuss the civil registration system. So countries use CRVS to record statistics on vital events such as births, deaths, marriages, etc. And there are several benefits to a well-functioning CRVS system. At the individual level, it can form the basis of a legal identity, which then gives the citizen rights to other public services, social protection, etc. And at the country level, CRVS systems can generate really important data on population dynamics, health indicators, as well as other essential statistical information that comes in handy for policy formulation, planning, and implementation. CRVS systems are also an important source of data on mortality. So on the prevalence and causes of mortality, which of course is the subject of our conversation today. So moving now to India specifically, birth and death registration was legally mandated in 1969 by a central act. And even though the mandate came under a central act, implementation is the responsibility of the state governments. Even back then, there was the understanding that it would take time to sort of build this CRVS system and make it uniform and universal. And so parallelly, the sample registration system was set up as an interim data source. And although it was supposed to be interim, we still continue to depend on it for estimates of births and deaths. Speaking a little bit about the process of registration, which many of you may be familiar with, birth and death registration has to be notified and registered within 21 days of the vital event happening. If the birth or death happens at home, it is the responsibility of the head of the household or a family member to register. If it happens at a health facility, it is the responsibility of the person or the the facility in charge. And in case death occurs as under a medical legal case, then it is the responsibility of the police. Here we move to speaking about death registration itself, which is our primary topic. So once the death occurs at home, facility, elsewhere, it is notified, it is registered in the system, and then a death certificate is provided to the family. But there are two important components to this, which is important to sort of remember. One is the level of death registration, which is an important component of death registration. So this basically refers to the proportion of deaths taking place in a country which are actually registered. And the way this is computed in the case of India is that you take the number of deaths registered in the CRVS, and this is then divided by the number of estimated deaths in the SRS. So this is one important piece of data that comes out of the death registration process. The other important piece is the medical certification of the cause of death. Both these pieces are really important because the level of death registration tells us who is dying and where. So is a certain age group getting affected, or is a certain geography being affected disproportionately by a certain cause of death? And then the medical certification part tells us how and why the deaths are taking place. So both of these are important elements, and I know the panelists will come back to this. My final slide is on just to give us some idea of what the current level of death registration is. And this goes back to the poll. Current level of death registration as of 2018 is actually 86% for the country as a whole. The areas in green that you would see on the map are the highest in terms of the level of death registration. But as you can see, the average hides a lot of state level variation. On the medical certification of death, our numbers are quite dismal. Only 22% of registered deaths actually include a medically certified cause of death. And again, here you would notice that there's wide state level variation. Our panelists today are going to come back to this and talk about this in additional detail. So without further ado, I will move towards introducing them. We have a very distinguished panel, as Rajiv mentioned at the beginning. And if I were to read their accomplishments, it would probably take me another 10 minutes at least. So I'm going to very humbly ask pardon from them. And for today's session, I'm only going to introduce them by their current job titles and affiliations. We will be uploading the full bios onto the website, the NDQF website, where this video recording from today will also be uploaded. So you'll be able to read more about them there. Our first panelist today is Dr. Faujdar Ram. Dr. Ram is a senior professor and ex-director of the International Institute of Population Sciences. So over to you, Dr. Ram.
Thank you very much. I hope you can hear me.
Yes, sir, we
Hello.
can hear you.
Hello, everybody. Today I am going to talk on the death registration in India. And you can see that there are 4 people who are engaged in this work. And I am probably the oldest one to present. I thought the younger one will present, but I think they thought I will be doing better job probably. So I would like to say that the first time I worked on this topic was for the Asian countries in 1981. And then for India and states, I worked on it in 1987. These papers were published in the local journals. And therefore, I kept my interest alive And then when Anurag Verma was a student at IIPS, he showed interest, and then we worked again maybe 4 or 5 years back, and that is how it comes. Of course, the count the date, everyone is talking about the importance of registration of births and deaths from legal point of view, from planning for public health or otherwise.
Sir,
So I'm not going
sorry to disturb you.
Yes.
Could you just put your presentation on slideshow mode, please? Thank you, sir.
Yes, sorry. No. So I'm not going to talk on this slide. The main why we started, I think I must say that Population Council showed the interest and approached me that can you work out on this topic, and maybe I think 6 months back or so, and that's how the team started working. So all are equally responsible what I'm going to present. Now I'm going to use two methods. One is the Bennett-Hurici method. It is based on the generalized population model, and now it is also known as SEG methods. So both are similar, and you can see the data requirement for this method. We need from two census age distribution, and also we need intercensal period all 10 years, the deaths by age. And of course, this method does not assume stable population. If anybody needs the concept, I would like to explain. But the second method, which came in very recently, 1+1, that's much actually, I should say, applicable at subnational level, because the first method is affected by the migration, net migration for the area, and also the quality of census, relative quality of census there. So, but this method is based on the random effect model, uses 110 country data for the period 1970 to 2015. It means it gives based on 2,451 country year data, which comes from the GBD. And logistic regression, which is used, is given on the screen. Only problem is that we need under 5 mortality estimates in this method. So if you want to estimate at the district level, you need under 5 mortality rate at the district level. In this case, we have taken from the NFHS4. You can see the data which has been used, how it comes from there. Now, data issue, everybody knows that sometimes some state, either sex breakup is missing, or age distribution is missing, or district level information is missing. So there are certain issues related to this. And I have listed only those states where something or other missing some year, the state which we are using in our analysis. That is why these states names are there. Other states, there may be other problem. Say like Gujarat has only, 2016, has only total registered death, no rural-urban breakup, no male-female breakup, and so on. So each state had its own peculiar problem. Uttar Pradesh, we had no age distribution or total deaths for many years, and therefore Uttar Pradesh does not appear in this slide. Just now we were talking about the label of registration. So here I have given you the label of birth and death registration, which is published in every annual report published by Registrar General of India. You have a birth also, death also here at 2 points of time. The major point which I would like to mention here, that there are some states where one can see there is a decline in the level of registration. But the major issue one need to be concerned with, I feel these estimates are actually overestimated, the coverage of the birth and death registration, because they are using the population, projected population, based on 2001 census. They have not updated to 2011 census, or they are not still using the latest population projection. So there will be minor upward figure I know you see 86%, but once you adjust or 78% for the deaths, if you adjust for the latest population projection, maybe it is around 72% for death, maybe 84% for birth. So there will be difference. That's the only point. I'm not sure why Registrar General actually does not update the population projection, because maybe the time series breaks down. Maybe registration goes down, then they have to explain. So maintain the continuity with the old projection. The major point I think one can see here, I have given for the infant mortality, infant death coverage, but we have worked for the below age 5 death coverage in the registration. You see that what is the status? You can see 17% of infant deaths are registered. So it's very measurable. You have better condition, maybe Haryana, Kerala, Karnataka, Maharashtra, and Odisha, and best probably the Tamil Nadu, which covers more and more infant deaths under the registration. So the major, I think, problem is here, the registration of under 5 deaths, where I think we need. One may say that because overall it may not affect the registration, because as we go with the time, the share of infant deaths or share of the below 5 deaths in the total deaths is very small. Like in Kerala, it is only 2% infant deaths of the total deaths in the Kerala. So even if there is some problem, it may not affect. But other states like Bihar, Uttar Pradesh, Rajasthan, Madhya Pradesh, they have almost close to 20% infant death share in the total deaths. So there would be issue related to. So this is the first point as far as the published report is concerned, and which we are using quite frequently. And they are not given by sex. I think the level of registration of death or even the birth should be given by sex, so that we know where is the problem happening. Now I move to the indirect methods, which is the Bennett-Horici method, as I have used 2001 and 06 and 1116. You can see the label. I'm not talking here. I'll talk in the next slide. But what you see, the major issue here, the death registration of female. This is the 5+ deaths. So the female deaths are much less registered than the male deaths. That's the issue. And this issue is also in the sample registration system. We published paper in Economic and Political Weekly. You can see that same issue is in sample registration system, and same issue is continuing in the civil registration, where female deaths are less registered than the male deaths. This is the latest method, Tim and Lopez, I call it, which was based on the Logit regression. And you can see that what is happening again here. This method can be used even for a sub-national level, like district. That is the advantage. Of course, the estimate here are very similar what I have discussed in the earlier slide. And just for you people, you can see all the estimates together. One is the level of registration published in the, this is the average of 5 I have taken, so it will not match with the published report. Then Tim Lopez method and Bennett-Horici or SCG method. No, it seems very similar. It is not irrationally, they are different in the 3 approach which we have used to assess the coverage of death registration. You may find the last column, it is more than 100% or so. It is sometimes because this method is affected by migration and relative quality of census. So just for information, say relative quality of information, you can see that in the southern states, net omission rate as per the census was 34 per 1,000 in 2001, but it is only 15 per 1,000 in 2012. So there is a lot of improvement. So that affects the actually the estimates upward or downward depending on the direction of change in this. Same
Dr. Ram,
thing is
sorry.
Yes.
Dr. Ram, so sorry
yes.
to interrupt you. The quick time check. Could you wrap up in about a minute, please? Thank you.
Yes, I think I'm almost close to my last slide. This is the district. You can see that out of 515 districts where data was available, 192 districts are less than 50% death registration, and mainly they come from Uttar Pradesh, Bihar, and Madhya Pradesh. So you can see that this is based on the Tim and Lopez method, and under 5 mortality is taken from NFHS 4. This is the map which gives the geographic attention you draw, that most of the problem here again, like all other demographic problems you have. Yeah, this is the registration. That's not important. What I at the end would like to say that this data from the civil registration system should be regularly published, and that should be published in conventional age group, that is 5 years age group. All India age groups are not published. Only state-wise age distribution is published, and that to 10 years age interval. So that I think should be seen, that should be published regularly, so that we create more and more research evidence where we are moving. My suggestion was that if can we get the unit level data from CRVS after removing the identifications of the household or the diseased person. We are also looking into the sensitivity of this method to mainly for the under 5 mortality, and also I think COP Council can do the similar analysis for gender, which we have not attempted in this paper. Thank you. Thank you
So much, Dr. Ram, and especially for the call out on looking at these, registered deaths by disaggregating and looking at age and gender, which is an important call out. Thank you so much. Okay, so we'll have a chance to come back to some of these issues during the Q&A, but if I may now proceed to our second panelist, Dr. Olga Jose. Olga is currently a technical advisor and project coordinator at the CDC Foundation, supporting the Data for Health CRVS initiative activities in India. So welcome, Olga, and over to you.
Thank you so much. Let me just set things up. One moment.
We can see the PowerPoint.
Do you see the PowerPoint or do you see the presenter?
No, I just see the slide.
You just see the slides. Okay, sorry. It's technology these days. You would think that it would be a little bit easier. Okay, so thank you so much for the invitation to speak today. It's a really exciting opportunity, and I could have definitely spoken about for 10 minutes on the answers that were given to the question on the leading causes of death. But instead, I will try to focus my presentation here. Let me see, sorry about this, on these questions that I have listed here on the importance of cause of death, variations in state performance, quality considerations, and interventions to improve the quality of cause of death. I'd like to first start by covering some basic components on cause of death so we're all on the same page. Starting with the reporting form, some of you may be familiar with it, others may not. What you see here is the WHO recommended medical certification of cause of death form, what's often called the MCCD form. The WHO is responsible for the maintenance of the International Classification of Disease, what's called ICD, which is the classification system of codes applied to conditions for determination of underlying cause of death, which allows for analysis. To ensure best quality coding of death, the WHO recommends a specific form for reporting cause of death, which you see here. And in India, Forms 4 and Forms 4A are the MCCD forms that are currently in use. And they have not been revised to meet the 2016 WHO recommended MCCD form, but in close inspection, you can see that the critical component, the table for reporting causes of death, time interval, and other significant conditions is included in both forms, Form 4 and Forms 4A. And it's important to be familiar with the reporting form as it presents the structure for the input, the causes of death that the doctors will report. And I'm just going to say here very quickly, I saw in some of the responses, you know, heart attack, circulatory system or traffic accidents as leading causes of death. And you would not want to report that on a cause of death form. You want to report the conditions. Was it atherosclerosis that led to the heart attack? Was it a pedestrian hit by a car that was the road traffic accident? You want that detail. Okay, but that's another topic that I can't cover right now in my 10 minutes. In addition to knowing about the form, it's also helpful to know about the cause of death process, starting with the death, which is then certified by a doctor. The form is submitted by to the registrar, along with Form 2 for the registration of the death. The MCCD form is then coded, and that information is submitted by the chief registrar at the state level to the RG's office and the analysis report for compilation and the analysis report that's available on its website. So now let me finally answer the question of the importance of cause of death by presenting a statement from a 2010 Lancet manuscript on child mortality. It's the first one that popped up into my search, but there are definitely more publications that are more recent. So it says 5 avoidable causes of nearly 1.5 million child deaths. So here you see the burden. The avoidable deaths of 1.5 million children in 2005. It continues with substantial differences between regions and sexes. So you have to keep in mind, you know, one size fits all approach would not necessarily be ideal to prevent these deaths. And then it goes on to present some interventions to potentially decrease these 1.5 million avoidable deaths. So in other words, the analysis of these causes of death was quite valuable in quantifying the burden and the population affected and proposing solutions to avoid further child deaths. And I really liked Dr. Ram's take-home message about access to data for the analysis and that timely access to data, because the data are very powerful in doing something about it. And that's why cause of death data is important. It's extremely valuable for policymakers and program managers. That's why the reporting of cause of death is actually stated within the CRVS legal framework, which in the case of India is the Registration of Birth and Deaths Act of 1969, which Dr. Goel mentioned at the start of this webinar. Specifically in Section 10, you see that state governments may require that a certificate of cause of death be submitted to the registrar. So note the wording may require. And in Section 10.3, you see more details on cause of death reporting. So I've covered the legal framework and cause of death process very briefly, but now I want to shift focus to performance variations. And in this table, I've presented just select states and union territories along with the overall average in India of registration completeness that we were talking about and percentage of registered deaths with MCCD. Now note, this comes from the CRS, the Registrar General of India's website, the CRS ORGI, which you see down below. So registration completeness is actually pretty high, 86% in India. So for the most part, it's pretty high. Not everywhere. You see some low performers, for example, in Bihar and UP. But what I want you to look at is the percentage of registered deaths with MCCD. So that's the MCCD completion among registered deaths. You'll see here in Bihar, that among the 35% registered deaths, only about 14% of those deaths had MCCD. So you go from the whole, you only have about 35% registered, and within that 35%, only 15% have MCCD. So that's just a fraction of the estimated 600,000 deaths that occurred in Bihar in 2018. That's a lot of valuable data that's missing for policymakers and program managers. Here you can see that death registration in India has increased since 1991, but MCCD of registered deaths has increased minimally. And when you think about efforts to increase death registration, we need to think about increasing MCCD completion as well. They go absolutely hand in hand. When a death occurs, we want the attending physician, if there's one available, of course, to certify that death. So you want that component included so that the form is then included in the registration of the death. It can be coded and that data be submitted to the RG's office for action. But we just can't focus on completeness. That's only one quality component. Here you can see the 6 leading causes of death in India from 2018. And ill-defined deaths are the 3rd leading cause of death. So this is symptoms, signs, and abnormal clinical findings not elsewhere classified. So going back to the point on the importance of cause of death data, remember that you want decision makers to be able to make decisions using this information. So if the data are poor, then evidence-based decision making is hampered. So if you're getting results, cause of death of heart attacks, or circulatory disease, you have a general idea, but what's the cause of those heart attacks? What's the cause, or what's the specific information or condition within circulatory diseases that resulted in death? You need that detail. Policymakers need that detail to be able to act on this information. So plausibility and accuracy are quality indicators along with completeness. Those are items that I've mentioned. And then other key quality indicators are representativeness. You want to know about all deaths, not just a select proportion of deaths, and timeliness. You'd like that data available as soon as possible and not 5 years later or 10 years later, because maybe the causes of death have changed a bit in that time period. There are various areas in which quality of cause of death data can be improved. Here's a list, but let me highlight 4 that we've supported in India through the Data for Health initiative. The training of medical students is an important intervention to establish good reporting practices. And through advocacy efforts, we were able to support the inclusion of competencies on MCCD in the recently revised MBBS curriculum. So that's a win for MBBS doctors, but now we also need to work on integrating these competencies in Ayush medical training as well. We've supported face-to-face trainings in Maharashtra on MCCD, so cause of death certification among doctors. And here you can see a manual that we've developed for distribution. The challenge with face-to-face trainings is bringing them to scale, which is why we're working currently with Tata Memorial Center to develop an online MCCD continuing medical education course that will be available on OmniCuris, a large CME platform in India. We've also supported MCGM in Maharashtra, Directorate of Health Services, in establishing mortality coding teams. This includes coders trained in ICD-10, data entry clerks, and IT consultants. In Mumbai, we're also working to support the implementation of IRIS, an automated coding system that will require a team. It still requires a team of well-trained mortality coders, but will increase the efficiency and standardize the quality of cause of death data. And finally, we've trained team members to support the analysis of mortality statistics through Anaconda, which looks not only at cause of death, but also the quality of cause of death and other mortality analyses. So our focus in data for health initiative or interventions, at least in India, thus far has been in accuracy and plausibility, but there's room to improve all components on cause of death. And one final point I'd like to make is that achieving good quality cause of death is a continuous process. It's not a one-time accomplishment, and if so, many of us would be looking for new jobs. So it's something that you continuously have to look at. And these are the activities listed that really need to be assessed on a regular basis and maintained to ensure that the system, the cause of death system, is best supported to produce good quality cause of death data. So thank you so much for the opportunity to present and share my thoughts today. And I hope I've presented some key points that we can then discuss further in the Q&A session.
Thank you so much, Dr. Jose. I think one of the key elements from what you're saying is, how do we increase that number, the 22%, and take it higher? I think is a big challenge. And so, yes, thank you for sharing your work on that. And I hope that during the Q&A, we'll have a chance to come back and talk a bit more about that. Okay, so moving on to our next panelist, Dr. Rakhi Dandona. She's the discussant on today's panel, and she is a professor at the Public Health Foundation of India, as well as a professor at the Institute for Health Metrics and Evaluation at the University of Washington in Seattle. So welcome, Dr. Dandona, and over to you.
Thank you so much, Dr. Goyal. Pleased to be here today. Good evening, everyone. As Neeta said, my role today is being the discussant on the two wonderful presentations that you've heard just now. Is my screen visible?
We can see it.
Yes, we can
Wonderful.
see it.
Wonderful, thank you. I would like to acknowledge my colleague Anil here, who works with the team on mortality. I will start with presentation one, Professor Ram's presentation on coverage of death registration. And that presentation, the theme of that presentation reminded me of this statement here that was published in Lancet journal many years ago, that there are people in Africa and Asia who are born and who die without leaving a trace of any legal record, official statistics. And they termed it as scandal of invisibility. And these words have stayed with me, because that's what is a fact when babies die. Babies who are born and die almost immediately after birth are neither recorded as birth nor as death. So we really have no idea how many babies were actually born and die without any registration. So the essence of the presentation was, are we making everyone count by actually counting everyone? Important issues were highlighted, and the first one being that how are we estimating the coverage of death registration, and which is estimated by the registered deaths, but the denominator is how many Indians die is actually an estimation. So unless we improve the estimation, there is only so much that we can do about coverage of death registration. And there are big issues with estimated deaths, because these deaths come from the sample registration system, and there are issues with it for why estimation is not, estimation needs to be addressed, and that's a topic for another panel altogether. But because we have issues with denominator, we have to resort to different types of methods to understand what the completeness of the coverage would actually look like. There are deaths that are not reported or less reported. Professor Ram's presentation clearly highlighted women are left behind while they're alive and even after they die. So this is the coverage, the level of coverage for India from 2010 to 2017. The yellow line is the male level of registration, and the blue is the female level, clearly way below the male registration. And very interestingly, this pattern doesn't change by if you look at it by less developed states, more developed states. You look at Tamil Nadu, you look at Manipur, Assam. Unfortunately, this pattern doesn't change. The difference might change, but the pattern really doesn't change. So clearly something to think about. The other group that goes missing is the babies who die either immediately or within the first month of birth. So for these babies, there's hardly any birth registration, and because there's no birth registration, that you can't register a death because you haven't registered birth. And there are issues why this is not done. But again, there are issues with community that we need to deal with to ensure that these births are registered, so we can understand these deaths. And I'll take you to another slide that highlights why this is important. All of us know that the deaths that get registered the most are also the ones where some financial issues are involved, whether it's property, whether it's pension, and which typically is associated with men in our country than women. So clearly these two are related. So the need for deaths to be registered is not seen as much beyond the financial issues that a family has to deal with. And these things were highlighted in Professor Ram's presentation. The other interesting thing that he highlighted was age. Unless we know the age at which people are dying, there's only so much you can do with policy making. These are the data to 2015, and as you can see, nearly 40% of all deaths that were registered in the system, in the CRVS system, had age missing. So clearly, we need to understand, so we need basic stuff like age and sex to be correct in the system to be available for us to make sense of the data that's available for us to analyze and look at what can be done for policy and program making. I've taken this, this map from Professor Ram's presentation, which is the distribution of completeness of death by districts. And as you can see, the more red it is, the worse it is. And I'm putting next to it this map of district level neonatal mortality estimates in 2017. It's very interesting, just by visual comparison of the two maps, you see wherever the red is darker here, you also see the map is darker there. So these are the districts where the neonatal mortality is higher, which is that you have more number of babies who die within the first month of birth. So clearly, for policy making, we to reduce these neonatal deaths, we need to understand this better. So it's interesting to see how these maps literally kind of can sit on top of each other, which kind of goes back to the point of understanding who is dying, when that person is dying, so that the policies and programs can be made accordingly. Community is also a big part of what happens with birth and death registration. It's just not all systems' responsibility. Community demand is an important issue. The deaths can happen in the community or at the facility, and then they get notified to the system. So clearly, it's important that community is equal participant in registration of deaths and births. Interestingly, as all of us may know, that the birth registration in India has gone up, way up. It's pretty decent, but the death registration, and there's a big variation. Even though 86% is the average death registration, there's a range. As Dr. Juice presented, Bihar is really low, for example. But there are not many examples of interventions. These are birth interventions and these are death interventions. There are not many policy or intervention examples to increase or improve the level of registration of deaths. So clearly, we still need to think a bit more of what incentives we can give to community so that they register all deaths irrespective of their interest in registering the deaths. For example, for birth registration, school admission is very important. So the birth registration has gone up. We need to be innovative to think how we can improve the death registration as well. There are options suggested with IEC to help strengthen, but we need to go beyond these generic IEC measures to understand how we can improve deaths of women, how we can increase death registration of neonatal deaths, for example, and across all age groups. Presentation 2, Dr. Juice talked about medically certified cause of death. Clearly, as she highlighted, it's important to know why people die so that the government or the Ministry of Health can actually decide what the public health action should be so that people don't die because of that illness or because of that cause. And the question we were asking today was, are we counting the deaths by the cause right? We do need to know the reasons why people die because, again, as highlighted very well in the earlier presentation, if you don't know why people are dying, you won't know how to stop it. So a good example is if you figure out that the deaths from heart disease and diabetes have gone up, so clearly the health ministry or the government has to have interest in policies and programs that encourage lifestyle so that these kind of diseases can be prevented. But they can do this only if we have this information available. High-income countries have a system set, and they use this information on an ongoing basis. But many low and middle-income countries like India do not have a system. And as highlighted in the previous presentation, we are way off to understand cause of death in India well. This relates to the Mentimeter question. What do we know about the reasons why people die in India? Now, there are two sources for it. The MCCD is what Dr. Juice was referring to, which According to that, the 2017 report, the diseases of the circulatory, so this is a very broad category table that I have here. Diseases of the circulatory system, which is where your heart attack comes, was number 1, followed by diseases of the respiratory system. The other major source of cause of death in India is the sample registration system. This table here is a combined table for 2007 to 2013 causes of death. Again, cardiovascular diseases are the leading causes according to this. Interestingly, the second leading cause here is ill-defined. So based on all the information collected, they couldn't really assign a cause of death. And the third one here was respiratory disease. It's important to understand where these come from. Now, the SRS comes from the sample registration system sample, includes rural and urban population, of course, mostly rural, given India is largely still rural. And what's important to understand is that this includes home deaths, so the deaths that have occurred at home, and the deaths that have occurred at facility. The data on cause of death are collected through verbal autopsy, which is not medical autopsy. This is conducted, the interview is conducted of the household members who are available at the time of death. Verbal is through the interview, you figure out, you ask signs and symptoms, and there are ways to then figure out what the possible cause of death could be. SRS uses physician coding, so physicians review this information and arrive at a possible cause of death. On the other hand, MCCD, with Dr. Juice presented, comes from the urban areas in select hospitals. That's not all hospitals in urban India, just select hospitals, and covers only 22% of all deaths. So these are only facility deaths which have medically, clinically assigned cause of death. So these two are actually not comparable. But most of the country has cause of death available only by the first method, which is less reliable than this method. When you put these two together, so the Global Burden of Disease study, some of you may have heard about it, puts these two together along with some other specific studies that have been undertaken to understand cause of death in India, and arrives at what possibly does it look like when you put these two together. So this is what it looks like, cardiovascular on top, followed by chronic respiratory diseases. So what I will finish by saying, what do we need to do? Some of these issues have been well highlighted by Dr. Juice. So the big thing is capacity building of the system, clearly. Skills of the medical doctors, the example that she's given, what they've done in Mumbai and Maharashtra, and not only medical doctors, along with the other relevant staff for coding. So this is just not medical doctors. This is a team of people working together to arrive for information to be available so that the doctors can arrive at a cause of death. You need a unique medical record for each patient, because many of these diseases that we are talking about are now chronic. We are talking about NCDs being the leading cause of death in India, not communicable diseases. So it's important to have a unique medical record for each patient where everything, clinical and lab findings, are documented so that doctor can review it and arrive at a cause of death. Training, such training is needed in pre-service training, and as Dr. Juice already highlighted, they have been able to get it into the MBBS, and that's the way to go in the MBBS system. Currently, MCCD is only in the urban areas, and that also is not a full coverage. So clearly, first needs to expand within the urban areas, and then of course we'll have to figure out ways to expand it to rural areas to cover facility and home deaths. It's not easy. I mean, this is the difficult part. How do you extend such a system to rural India so that we can actually get medically certified deaths for people who die in rural India, and also at home, because majority of the deaths in India still happen at home. So clearly something to think about, and lots needs to be done for us to get there. Lastly, timeliness of whatever is available. Both the presenters have raised this issue of availability and timeliness of what's available. The sample registration cause of death report that we have for India is not available after 2013, and we are now in 2020. So clearly, if we do not have understanding of what's killing Indians now and have appropriate programs and policies, there is no way we can actually make difference in the years to come. So again, the need to have an ongoing system that's routine available is very important. I will leave you with this slide. This was work done by Alan Lopez and his group trying to, so globally they rated, categorized the CRVS systems based on a variety of indicators. And this was done in 2012-15, between 2012-15, and India, as you can see, is in red. This was done a few years ago, and from whatever changes have been made over the years, it's probably orange now. But clearly, both the presenters have highlighted for us to move from this orange, let's assume we are orange now, to green and then to blue, lots needs to be done. But we cannot keep ignoring it because there's so much to be done. We have to start soon for it to get to blue someday. Thank you.
Thank you so much, Dr. Dandona. That was super interesting. If I may, the questions have started coming in, and so we have a list of questions. And if I may request all of our panelists to please come on to the video, and maybe we could now engage, you know, as we promised, we said dialogues. So maybe we can do a little bit of that now in the Q&A section. So I'm going to ease you into the questions very gently. The questions are not addressed to any one panelist, so please feel free to jump in, and that's where having you all on video makes it easier. Whoever would like to respond is welcome to do so. So we have one question from Dr. Pruthvish. I hope I'm saying the name right. This one is, which are the countries where death statistical reporting is the best and almost 100%? Anyone who would like to go for it is welcome.
I'll quickly respond. I think that Dr. Dandona in her last slide presented the very nice map of CRVS performance index, and that looks at various components of a CRVS system. So I would refer to that map. I think the publication is Lopez et al. From maybe 2018 or 2019. So I would refer the person who asked the question to that manuscript.
Oops, sorry. Yeah, so next we have a question regarding the fact that, and a number of people have asked this, that the problems exist. What are the solutions? How do we actually fix the problem? How do we improve registrations? And then related to that is the question of incentives, that where death registration is higher, are there incentives given? And when households are landless and have no assets, going back to the point that was made in terms of financial reasons why deaths may be registered. So when households are landless and have no assets, what incentives would work for them in order for them to be motivated to step up and complete the death registration process? So over to you all. So basically questions around solutions, incentives, how can the government step in and help to improve this? Perhaps, Dr. Dandona, what you were mentioning earlier about communities as well and the role that they can play. Open to the panel to respond.
Maybe I'll go first. That's a very interesting question, and that's a question that all of us are grappling with. As I presented, it's easier to think of incentives for birth registration because it's something to look forward to. There is this life, you know, someone's going to live for years and then die. With death, the life is done. There's nothing to look forward to. And the only thing to look forward to at a household level is if there are some money-related issues. So we need to understand, we definitely need to understand that better. Having said that, on the system side, efforts have happened to make to change that. So if you can't change community attitude to increase the death registration, the deaths can be registered, can be notified, not necessarily by a family member. So let's say we talk of this village, the example that you've given of a landlord, of a landless person. The ASHA in that village, the A&M in that village, the grassroots level worker in that village can actually notify that death, so that the death gets notified in the system and the system can then do something to register. So there are ways to figure out, so the system is working to figure out how the notification of deaths can become better so that they can be registered. So right now the problem is they're not even notified. And this we need to get into a bit more in detail rather than generic things. For example, road accidents. Our previous work has shown that 25% of road accidents are not reported anywhere, the deaths. And very simply because if there is no one, if the person doesn't know who hit this person, there is no compensation, there's no third party from here you can claim compensation. People just take the body of the victim away and deal with the death rights because there's no one else available. There's no financial incentive to worry about who was on the other side. So clearly we need to understand details not only by gender, by age, and also maybe by types of causes of death that we are talking about. So lots to do, but some work has already happened. Thank you.
Yes, please go ahead, Dr. Ram.
Yeah, I just wanted to say one thing, maybe related what we are discussing. First, I feel very strongly that system must have, that confidence and knowledge that data is very useful for the policy and planning. Unless system realize that, it becomes very difficult. That is the first thing. Second part, I think, again, the system and researchers are those who are creating the evidences. There has to be a continuous dialogue, and so that researcher creates or generate evidences that what is the wrong going on around. Now, I would like to just narrate one example from Maharashtra. Maharashtra, when the infant death auditing was going on, there was a policy or instruction that infant death should be audited, why the child died and all that. And probably it was linked also with some kind of punishment or something to A&M and those people. What happened? A&Ms were the informer for the death registration. So they stopped informing the system that there is an infant death. And there was a committee, I was member of that, and civil society meetings happened and all that. Government issued a circular, no health worker will be informer to the infant. Only it is Anganwadi or revenue department. So there are issues related to, that system. There are integrated many system involved, government system, not only health department, because if I have 99% institutional delivery, what is wrong that then I don't have 100% birth registration? And even the CRVS report itself says 80% of the deaths are attended or attention is given by medical officers, qualified doctors. Then what is wrong? They are not certified the cause of death. So there is a missing link between one system, reporting system, and registration. So that is the issue, I think, more than public and other awareness, of course, is important. Utility of that doing something is important. Once people realize it is important, like for child education, you need birth certificate. Now everybody try to register. Similar things are not there for infant days, registering the child days. That what is the use? One child has died. So what is the utility? They must be actually told that. Thank you.
Yeah. Thank you, Dr. Ram. I'm sure this will come, the next series of questions will come as no surprise to our panelists. These relate to COVID and how you think COVID is affecting. There are, as you know, there are a lot of debates about, the death rates. So general questions around, when it comes, what are the effects of COVID? The flow of information around maternal, newborn, and child death has been severely affected by COVID. What can be done to improve this? How is it affecting death quality and death registrations, and what are short and long-term implications? Again, open to anyone. I'm sure all of you have experiences and feedback that you'd like to relate. So maybe we can go around, around the panel, and each of you can share.
I'm happy to start off.
Please do.
And you know, and I think this goes back to the point that Dr. Ram said about availability of data and the timeliness of data availability. I think for COVID, it is very important to make this available, this data available as soon as possible, so that analyses can be done. It will be tricky, you know, with the work that I've been doing in cause of death. We've noticed not only in India, this is a global issue, that the reporting of cause of death, at least for confirmed and suspected COVID cases, is probably underreported. And that's why there's this approach of looking at excess mortality. So comparing the mortality of 2020 or maybe starting late 2019 and whatnot, looking at the burden of deaths, and is that in excess to what is usually seen in a community, accounting for you know, differences in times of years and whatnot. So I think that that will be important to look at. And I just want to go back to that, the previous question about the solutions for the cause of death, because again, Dr. Ram noted something very important. 80% of deaths are attended, or an estimated 80% of deaths are attended. However, MCCD is about 20% in India. There needs to be this push towards motivating doctors to fulfill what is stated in the legal framework of certifying the causes of deaths. You know, that the language in the legal framework right now is may submit, so it's optional when you have that may. But I think a low-hanging fruit is at least working towards ensuring that doctors who attend a death certify that death so that's available, and then making that data available on a timely fashion for the analysis for these key issues such as COVID and other types of deaths. Over to others, please.
Please go ahead, Dr. Dandana.
Nita, may I? Thanks. I will, you know, COVID is one thing. I will not get into how much underreporting that's happening because of COVID. Researchers who've been in this field, either on implementation side or trying to understand what causes of death or what the level of underreporting is, all of us have been worried about this underreporting and the issues with cause of death for a long time. It's not that what we're finding here is new. It's not that because of COVID, this has happened. Because of COVID, what's happened is that it's all come out, it's all become a public knowledge. There's a pressure to, you know, the issues with the system, the gaps that we need to address are more visible. You know, there's more strength now to saying that if we don't change this, we might continue to have, you know, continued issues. So it's just not COVID. I think COVID is one example, but we need to have cause of death across, irrespective of COVID death or not COVID death. If you remember the slide that I showed, majority of the cause of death in India is based on verbal autopsy, right? So the question around whether we understand maternal deaths properly, no, we don't. We don't, because most of our data for maternal deaths actually comes from verbal autopsy. It doesn't come from medically certified cause of death. So clearly, COVID has brought this issue up front, something that we can't ignore anymore, and the system needs to, you know, worry and prepare about it. I want to go back to the issue about accountability, which Professor Ram raised, and it's a very important issue. So most of the deaths in India are actually home deaths. Only 1/3 of the deaths are institutional deaths, irrespective of the age group. But what's important is the accountability issue that he raised for facility births that die later, for neonatal deaths, babies who die almost immediately at birth or later. Because of those accountability issues, what's happened is those deaths are now being pushed outside the facility, which means that if you know that this baby is unlikely to survive, but because there are accountability issues, the baby is referred elsewhere. So the baby could simply be out at the main gate of this hospital where the delivery happened and die on the way, you know, reaching the referral hospital. And that's because of accountability issues that Professor Ram highlighted. So clearly, what we need to do with deaths is fairly complicated. And the system is trying to work around those complications. Of course, not all loopholes are plugged in, and it takes time for those loopholes to be plugged in. But clearly, the loopholes have been identified. One of the recent things that has happened is CRVS portal, which is immediate registration of births and deaths, But very interestingly, so the system is a facility birth in public sector is simply put again by a data entry operator in the portal, and it is actually notified to the system that here there's a baby born or there's a baby who's died. But many data entry operators have understood it as that I have to keep it saved, but I have to enter it in the system only if the family comes to demand a certificate. So clearly there is an issue with implementation. So you have a system, but it's not implemented the way it's meant to be implemented. So, and that's why you see the death registration has actually gone up because of the system in place. So clearly more needs to be done, but efforts are being made. Thank you.
Thank you, Dr. Dandona. Dr. Ram, any thoughts from you on the COVID angle? I think we still have questions coming in, but I think this may be all we have time for. So any final comments from you, Dr. Ram?
I think I haven't worked on COVID, anything, but as per many newspaper reports, there also I find that majority of cases age is missing and sex is missing in the, you see the unit level data. There also it is like MCCD only, that 80% of the cases age is missing, even sex of the patient is missing. So that is, I think, very, I feel that all doctors are working under pressure, I know, but you can't forget to write the sex of the patient at least. I mean, whatever pressure you have, somebody may be filling the form. So patient is somewhere, form is filled somewhere, so they cannot see the patient. Otherwise, by seeing patient itself, sex can be filled, if not the age. So this missing information, I think, and because of what Rakhi is saying, accountability, we are not bothered. Nothing will happen to me if I don't record this. That is the attitude we have. So that's my perceptions. Thank you.
Thank you, Dr. Ram. Dr. Dandona and Dr. Jose, any final thoughts from you?
Yeah, I was just wondering what was the answer for Bangladeshi versus Indians.
All right.
That's the only one that's not answered.
We'll get Rajiv to answer that just as soon as he comes in. Dr. Jose, any final words from you?
I think just to reiterate what Dr. Dandona mentioned, this issue about challenges, in increasing CRVS or birth and death registration, increasing the completeness and the quality of cause of death data, whether it's COVID or any other disease, this is a conversation that's been ongoing. I do agree that the publication on the scandal of invisibility really heightened this work. We still have a lot of work to do globally, and it's wonderful to see that this webinar has been hosted here to talk about this further, because I think that there are opportunities to improve the system in India. There have been some interventions supported to make those improvements, but further steps need to be made. So thanks for allowing me to participate today.
Thank you so much to all of you for your being on the panel today and sharing so many interesting ideas. I know this is a subject we can all talk about for the next 2 days, probably non-stop. I know you all are very passionate about this subject. Thanks for sharing some of your insights with us. Rajiv, over to you.
Oh, thank you, Nita. It was very engaging. It's very engaging session right from the beginning, from the Mentimeter questions from there on. And here's the answer to the Bangladeshi versus Indian is Bangladesh wins. They have a year extra life than Indians. Right now, we have to beat them at some point of time, like in cricket, I just want to thank all of you. It was wonderful to have you in short notice. All of you agreed to come and talk. It was wonderful, and thank you all of you. Anita helped us to connect with Olga, and I knew other 2 panelists anyway. So it was very good teamwork, and the teamwork also was due from the NDQF team. They worked very hard for this. Particularly, I would like to mention Trisha Chaudhary and Radhika Dhingra, though you know already because they were in touch with you. they are the engine of all the webinars we have. I'm sure, and thanks all, of course, to 100+ participants who joined this boring topic of death and the sad topic of death and all these things, but they still came and heard us, heard all of you. Thanks, and we'll come back like with another issue next month. Until then, good night, everybody. Stay safe, stay well. Bye bye.
Thank you very much. Bye.
Bye.
Thank you. Goodbye.